As you can see, World Health Organization recommends that states help governments, help services to improve people disability in their function and their level of independence. So, to permit disabled people to come back home and to restore their functions, above all GAIT, assisted technology has been developed to achieve the goal of working independently. Task-specific repetitive training is the most effective training in recover functions. So it is possible for GAIT and it is possible for arm functions. The first treatment approach to improve GAIT function is treadmill training with the body weight support. But as you can see later, human resources must be available because manual assistance is very considerable in some cases. To reduce manual assistance has been developed GAIT machines with the principles of exoskeleton or end effector principles. Here are some examples of this robot GAIT that is exoskeleton, Locomat, Lopez Alex, and then the effector like GAIT Trainer 1, Haptic Walker, and Geo System. Among them, only Haptic Walker and Geo System permit to the patients to train in stairs climbing up and down. All the others can train the patient to walk on the floor to different velocities, but only walking on the floor. This is the inclusion criteria we have to permit a person to receive a training with a robot-assisted device. There are some exclusion criteria that are high spasticity, that doesn't permit the person to receive this kind of training, limitation of the joints, and severe cognitive and behavioral problems that cannot permit the person to comply the training. We have two devices that permit stairs climbing up and down. And because patients that come back home often need to climb up and down stairs, this is an important task that we can reach to improve independent living. We, in our institute, work above all with brain injury patients, so we have collected data about the results in these patients. We have the treadmill with the body weight support. And so you can see that we need two therapists to put the patient on the device and to permit the patient to make the GAIT pattern, because sometimes therapists must hold the leg, the parietal limb, to permit the swing phase of the GAIT. We have an image of the GAIO system that is a completely automatized device where the patient can be put on these 2 foot plates where the feet are fixed and the movements are programmed by a computer system, where we can program the length of the step, the velocity, and the height of the step if we want to train the patient to climb up on the stair. Here we have the position where the patient is put, then we can see how the feet are able to move in their ankle degree, and we can program the ankle degree we want to reach to permit a correct gait pattern. The device is programmed to permit the patient to have repetitive movement. This is the principle of the repetitive task-oriented rehabilitation that has been seen the most effective way to improve functions. We have upper limbs devices too, so we can improve upper limb functions. That is the most problematic situation in patients with hemiparetic disease. We have some devices which have different degrees that permits different degrees of movements. The first that you can see here permit the movements of the shoulder and the elbow in some 2, 4, or 6 degrees of movements. So they can improve proximal movements, but not all of this can increase hand functioning. Amadeo is the device we have in our Rehabilitation Institute, and it permits the movement of every finger separately. So we can train this patient to move every finger to different degrees of movement, to different speed, so they can reach a better functioning. This device can permit passive, assistive, and active movements, and even interactive activity with computer-assisted training, so that the patient can receive a feedback about his movement, not only by his own movements, but also by the goal he can achieve in this training by the monitor. We have seen that all these devices increase proximal movements and proximal abilities, so shoulder and elbows, but we have some results now that even the hand movements and the hand functions is increased with this kind of training. We have not yet results about the activity daily living scales, but we think that to collecting more data about this kind of rehabilitation and choosing a better evaluation scale that can detect how the arm and the hand function is investigated, we can find some interesting result. For this kind of devices, we have some exclusion criteria too, that are apraxia, heavy sensory loss, and high spasticity, such as we said before. This is the situation. Now I'll speak shortly with a case report for a technology device for communication. We made a complete evaluation of his situation, not only neurological evaluation, but also social, occupational, cognitive and behavioral evaluation. And we saw that he had cognitive function completely normal. So we needed to give to him a communication device to permit to him to communicate his need. We chose a high tracking device with a software that we could give to him even if when he was in bed. So after a long training, he could receive this computer-assisted device that permit him to speak to other person, and so he can normally be included in his home life.
I'll be speaking on behalf of Dr. Ester Stefoni. She is the social worker at Santo Stefano Hospital, and she's responsible for placing patients back into their home life after their therapy. In order to highlight the importance of the transition from rehabilitation hospital to social reintegration, I looked to the community-based rehabilitation CBR guidelines. They focus rehabilitation on enhancing the quality of life for people with disabilities and their families, meeting basic needs and ensuring inclusion and participation. In Italy, rehabilitation has been defined in the Ministry of Health guidelines, a process of solutions to problems and education during which a person with a disability is brought to the best possible quality of life as far as physical, functional, social and emotional aspects are concerned, with as little restriction as possible in the performance of self-care activities within the limitations of his or her disability and range and quality available resources. A process which, in the case of serious disability, must involve the disabled person's family or those close to him or her, as well as the general environment in which he or she lives. There are two types of activities for rehabilitation. One is a medical rehabilitation, which we've seen before, and the other is a social rehabilitation. But one cannot function without the other. The first is to rehabilitate, the medical side. It is the phase when interventions aimed at recovering and supporting the learning skills of useful life skills necessary for satisfactory reintegration are evaluated and activated. The social rehabilitation is social reintegration and active integration. It's the phase when the subject experiences the life skills acquired in the social relations of everyday life. Therefore, the leadership of CBR programs is not restricted to professionals in healthcare, education, vocational or social services. CBR programs involve the people with disabilities themselves, their families and communities, as well as appropriate professionals. Here we can see a graph of the model of the rehabilitation. It begins with the hospital and then moves on with rehabilitation, moving then on to social reintegration, which eventually should lead to a form of autonomy for the patient. And all these pieces of the puzzle should fit together. In fact, the social work mission in rehabilitation is to favour and promote the reinsertion of the person into the family, society, work, after he or she has regained the ability to live independently. This is realised through family support, a coordination of resources, network intervention, preparing the environment to help the person with their new life experience, and communication of the casework, communication of the individual's needs to all services involved. The real success of a rehabilitation programme can be measured not only by the functional abilities that are regained by the person, but also by the increased quality of life, which means relationships with others, work and accessible environments. The contextual factors, environmental and personal, are very important for the person. The studied technologies for the person who lives in a determined environment contribute in a determined way to realise the maximum independence and the maximum autonomy possible. Technologies for accessibility are useful for home life, supported living, workplace, school environment, public spaces and transportation. We're now going to look at two examples of disabilities. The first is a congenital disability. This lady is called Antonella, and she suffers from the effects of polio contracted in infancy. At 16, she came to Santo Stefano and stayed for 9 years for treatment, after which she decided to move out and begin an independent life. And she was only able to do this with thanks to technology. Here we can see the everyday activities that she has to achieve through technology. It's all automatic, from the gate to the door, to the opening of shutters, to her wheelchair. Antonella has written an autobiography describing her experiences, and it's aptly entitled Disabled? Who? Me? She's a very remarkable lady. She's also created her own website, and she works from home, and she works part-time at the local pharmacy. And she's purchased her own minibus that's specially adapted for all of her transport needs. And in fact, she rather enjoys travelling abroad in a minibus, and is known to travel quite some distances for her holidays. She's a very independent lady. This gentleman is called Marcello, and he was living a very active, normal life until he suffered a thrombosis, which took away his ability to walk. He lives with his wife and daughter and uses a motorised wheelchair. Antonella has actually helped Marcello prepare for his new life. She's helped him with preparing his new home environment, and she's also been giving advice not only to him, but to his family. I must say, however, for both of them, Antonella and Marcello, the return to home and normal everyday life was not and is not easy. This is because even though we are in the 21st century, and though there exists a vast range of available technology, it is very expensive, and at least in Italy, there is not a specific law that provides finance for technological facility within the user's daily environment. We wish that the purchase and the use of assistive technology for an independent life will be encouraged also by the law that facilitates the purchase. Thank you for having invited us to this initiative.